Welcome to the recent approvals episode of the ASCO University Weekly Podcast. My name is Linh Alejandro. I am a clinical oncology pharmacist at the University of California, San Diego Health Systems. Today, we will discuss the approval of Olaparib for germline BRCA-mutated metastatic breast cancer. As a background to today's discussion, about 5 to 10% of breast cancer patients carry a germline BRCA1 or BRCA2 mutation. Alterations in BRCA leads to a high predisposition to breast cancer, with the lifetime estimates as high as 84%. BRCA1 and BRCA2 are tumor suppressor genes that repair DNA through the homologous recombination repair pathway. Poly-ADP ribose polymerase, or PARP, are a family of enzymes that repair single-stranded DNA breaks, mainly through the base excision repair pathway. It is found that treatment of BRCA-mutated tumors with the PARP inhibitor leads to an accumulation of DNA damage and apoptosis, an effect of synthetic lethality. Currently, PARP inhibitors such as Olaparib, Rucaparib, and Niraparib are FDA approved for BRCA-mutated ovarian cancers. On January 12, 2018, Olaparib was approved by the FDA for the treatment of patients with germline BRCA-mutated HER2-negative metastatic breast cancer who have been treated with chemotherapy either in the neoadjuvant, adjuvant, or metastatic setting. Patients with hormone receptor-positive breast cancer should have been treated with the prior endocrine therapy or be inappropriate for endocrine treatment. FDA also granted marketing authorization for BRCA analysis CDX tests used as an aid in identifying breast cancer patients with germline BRCA mutations. The approval of Olaparib in germline BRCA-mutated metastatic breast cancer was based on the results of the Olympiad trial published in the New England Journal of Medicine, a phase 3 open-label study randomizing patients with germline BRCA mutation and HER2-negative metastatic breast cancer who had received no more than 2 previous chemotherapy regimens for metastatic disease. 302 patients were randomized 2-to-1 to receive Olaparib 300 tablets twice daily, or standard therapy with a single-agent chemotherapy of physician's choice. Standard therapy included the choice of either capecitabine, eribulin, or vinorelbine. The primary endpoint of this trial was progression-free survival. A significant improvement in PFS was achieved with Olaparib in comparison to standard therapy with a hazard ratio of 0.58 and a p-value of p of less than 0.001. The median PFS with Olaparib was 7 months versus 4.2 months in the standard therapy group. A response to treatment occurred in 59.9% of patients in the Olaparib group compared to 28.8% in the standard therapy group. The trial also included a pre-specified analysis of overall survival, which demonstrated the Olaparib group had a median OS of 19.3 months versus 19.6 months with chemotherapy. The most common adverse effects with Olaparib include anemia, neutropenia, nausea, vomiting, diarrhea, fatigue, headache, and decreased appetite. The rate of grade 3 or higher adverse events was 36.6% in the Olaparib group and 50.5% in the standard therapy group. The approval of Olaparib in germline BRCA-mutated metastatic breast cancer demonstrates a current paradigm of developing drugs that target underlying genetic causes of cancer. It is important to keep in mind, however, that patients with prior platinum exposure were included if they had not progressed well on platinum treatments. The impact of Olaparib in platinum-resistant germline BRCA-mutated breast cancer is unclear. Olaparib resulted in a 2.8-month longer PFS compared to standard therapy, although there was no significant difference in overall survival observed between Olaparib and standard therapy. The trial was not powered to assess the differences in OS between treatment groups. The analysis of overall survival may also be confounded by subsequent breast cancer treatments, in which some patients in the standard therapy group went on to receive treatment with PARP inhibitors. From a diagnostic perspective, the approval of Olaparib in breast cancer also implies the need for BRCA testing, especially in HER2-negative breast cancer.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.